Good morning, everyone. Myself, Dr. Pritish Mahanta from Department of Medicine, is presenting today's seminar topic seizure disorder. Seizures are episodes of neurologic dysfunction caused by abnormal excitatory activities of neurons, characterized by a sudden change in senses, perception, motor activity, or behavior. Seizure occurrences with motor activity are referred to as convulsions. Unprovoked seizures are those with an unknown etiology or those that result from a pre-existing nervous system disorder. Epilepsy is a disorder consisting of recurrent unprovoked seizures. Status epilepticus is a recurrent seizure activity lasting greater than 5 minutes or without return to baseline mental status between seizures. Epidemiology occurs very commonly. Lifetime prevalence is 8 to 10%. Roughly 1 to 10% of emergency room visits are due to seizures. 25% of these emergency room visits are first-time episodes. Risk of recurrent seizure after first episode is roughly 40%. Seizure phases. There are three phases: aura, ictal, post-ictal. Aura. Initial warning or trigger prior to seizure episode. Individual may realize a seizure is about to happen. Ictal phase. Initial onset of the seizure episode as well as the episode itself. Actual seizure symptomatology is manifested in this phase. Post-ictal phase, period after the seizure episode during which the individual is disoriented, may last up to 2 hours. This is the timing and the phase. Seizure phase, that is aura phase, up to 1 to 10 minutes. That is then ictal, beginning of the ictal phase and continuing of the ictal phase is the actual seizure phase. That is 2 to 3 minutes. Then post-ictal phase is 15 minutes to 2 hours. Then we come to the pathophysiology. In pathophysiology, there are main two pathophysiology, that is inhibition of the inhibitory pathway, and second is glutamate pathway, that is excitation of the glutamate pathway. The first is that inhibition of the glutamate pathway, that is GABA. That inhibition of that GABA pathway. In GABA, there is the GABA A receptors are there in the postsynaptic membrane. In postsynaptic membrane, when either the GABA is not released, there is dysfunction of the GABA, or the membranes which are attached to the postsynaptic membranes, they are less stimulated, for which the GABA cannot enter, and if it cannot, actually in normal process, if GABA enters, then chloride ions enters to the postsynaptic membrane, due to which there is a negative charge, more negative charge in the postsynaptic membrane, due to which it occurs hyperpolarization. Due to hyperpolarization, it decreases the action potential and the seizure activity doesn't take place. If this pathology doesn't happen, if GABA doesn't go, the chloride ion doesn't go, then there will be activation of the membrane potential and it will lead to seizure activity. This is one pathway, and second pathway is the glutamate pathway. Glutamate pathway is that glutamate, there is glutamate release. If there is a glutamate release, it binds to two receptors in postsynaptic membrane, AMPA receptor and NMDA receptor. When glutamate releases, due to that in normal pathology, that in postsynaptic membranes, the positive ions like our sodium ions, calcium ions, they enters into the cell, due to which the positive increases. After more positive is there, then it will lead to depolarization of the membrane, due to which the activation of the membrane potential, which will lead to excitation, and the not potential will be there, and if this continues, then there will be seizure activity if it is not controlled. Okay, these are the two main pathways, that is glutamate pathway and inhibitory of GABA pathway. That is failure of inhibition. This is GABA pathway, intercellular. Goal of management is to restore inhibition of seizure activity. This is also loss of after hyperpolarization, excess glutamate stimulation, loss of the surround inhibition, increase in intracellular calcium from glutamate. Clinical presentation. How does it present in our body? There is focal seizures. Focal seizures with retained awareness depends on the location of the seizure activity. May present with various sensory, autonomic, motor or psychic symptoms. If that focus in on frontal lobe. If the focus and frontal lobe does our most of the motor activity, then motor activity there can be like movements of the hands in a uncontrolled movements of the seizure activity occurs. If that occurs in our temporal region or parietal region, then those control the sensory. Then patient can have a sensory that I mean, can smell, can see, can sensory impairment can occur to that. Okay, there is various sensory, autonomic, motor, or psychic symptoms according to which area of the brain it is involved. A particular area is involved in focal seizures, which altered awareness, most common type in adults with epilepsy, may engage in automatism, repetitive, unconscious behaviors. Facial grimacing means uncontrolled, lip smacking, like lip smacking, chewing. Patient doesn't know, but he will do the chewing also. Repeated movements will be there. Then the next one is focal to bilateral tonic-clonic seizure. At the presentation, it will start with focal seizure, but it will lead to tonic, that is generalized seizure. Previously also called secondary generalized. Start as focal seizure, then progress to the generalized. Generalized means involving both the hemispheres of the brain or more areas of the brain. It will be generalized. That is generalized seizures. Generalized seizures of different types, absence seizures, previously called as petit mal, and typically occur in childhood, last for short periods, 5 to 10 seconds, present with loss of awareness or behavioral errors. Myoclonic, short, sudden focal muscle contractions will be there in myoclonic. Tonic, focal stiffening of the muscles. Tonic means stiffening of the muscles, and clonic means movement of the muscles, abnormal jerking or shaking of the muscles in the arms, neck, or face. Tonic clonic means combination of the both, stiffness and movement, both tonic clonic. Okay, most often it leads to convulsive. Atonic. Atonic means loss of the tone, means he will suddenly collapse. There will be loss of the tone or stiffness of the muscle. Opposite of tonic seizures. Drop attacks are most common among children, often related to falls. Means the child can fall from bed. In children happens sometimes. Types of seizures and classification, this that is only the same only, that it is a chart. Focal three types. Seizure activity starts in one area of the brain. Focal retains awareness, sensory autonomic, motor psychic, focal altered awareness. This one that I explained, that is only just start only. Diagnosis. How will we diagnose the seizure? Initial evaluation and stabilization centers around screening for hypoglycemia, hypoxia, and hemodynamic instability. Their proper history is very important. Interview witnesses whenever possible. Without a witness, the diagnosis is often more difficult. Identify onset and progression of symptoms. Find potential triggers for seizures. For example, non-compliance with the anti-epileptic medication, which he tests regularly, but he has missed the dose. Then questions that can determine which type of seizure is happening. Was there a warning or aura before the spell? What happened during the spell? Does the individual remember the spell? Was the individual post-ictal? How long did it take back to baseline condition? How long did the spell last? How frequently have the spells occurred? Are there any associated precipitants? In post-ictal, that is, in post-ictal, there can be torse paralysis. Torse paralysis means the retention of the paralysis after the seizure. It happens in neuro test, you may see that is torse paralysis occurs. Physical examination, type of seizure activity, changes in level of arousal, focal deficits, pupillary changes. Physical findings are often normal after resolution of post-ictal period. Examine seizure-related trauma secondary to a fall. After a fall, there can be trauma. So, in generally in neurology, if we see, the seizure can occur from like intracranial hemorrhage, subdural hematoma, extradural hematoma. This can also lead to a seizure. Tongue biting has high specificity in ruling out psychogenic non-epileptic seizures and syncope, because in the tongue bite occurs due to that abnormal chewing, due to which he doesn't have control, for which the tongue is there and it occurs bite of the tongue. Urinary or bowel incontinence can occur. Torse paralysis, the seizure is followed by brief period of temporary paralysis. Laboratory evaluation, what does we do test? In we do CBC, basic metabolic panel like elliptic AFB, calcium and magnesium levels, pregnancy test for women of childbearing age, urine toxicology, prolactin test. It is very important. Prolactin test obtained shortly after the seizure can differentiate epileptic from non-epileptic seizures. Those who are mimicking that their seizure, we can do just prolactin levels. It can show that he had actually had seizure or he didn't have seizure. Serum levels of anticonvulsant agents for determining the baseline levels, potential toxicity, lack of efficacy, and non-compliance. In most of the patients, what we give drug, it is not adequate level. We can know from this test that does it have the adequate, which we give drug, is it adequate, dosing is adequate, or we are doing an overdose, or we are giving a dose that is not having any effect on the patient. So we can change the anti-epileptic drug. So this is the test. Neuroimaging. Routine neuroimaging is not indicated in someone with previous seizure history. Imaging with brain CT or MRI recommended for new focal neurologic findings. Seizure activity without known etiology. Non-contrast CT in the emergency setting to screen for immediate threats. That is structural cases, throats, bleeding, that I was saying, intracranial hemorrhage, hematoma, and brain MRI is most useful for new onset seizure due to any mass or anything neuropsychiatric. It can also cause seizures. For finding that cause, we can do brain MRI. EEG test that uses electrodes to monitor the electrical sensitivity of the brain and thereby detect any disorders. Indicated for those who do not return to baseline consciousness in the emergency setting. Included as a part of workup for new onset seizures also. More specific in adults than in children. Video EEG monitoring is the standard test for classifying type of seizure or syndrome, diagnosis of pseudo seizure that is psychiatric related. Examination. Electrodes are placed on the scalp and connected to a computer. The computer outputs lines of brain electrical activity. In EEG, can use surface electrodes placed on the surface of the skin or scalp, which we do most commonly. Cortical electrodes placed on the surface of the brain at the time of surgery. Depth electrodes inserted deep into the brain to detect deeper foci of seizures. Abnormalities on an EEG may include epileptiform discharges, focal slowing, diffuse background slowing, intermittent diffuse slowing. This is that is beta. Generally, three are main: beta, alpha, and theta. Delta is also there. Beta in beta, that is greater than 13 hertz, that is greater than 13 waves per second, present in EEG of healthy people, can be caused by medication, benzodiazepines, or may indicate muscle activity artifact. That is beta, that is 1 second, it is a greater than 13 hertz, it is normal. Then alpha 8 to 13 hertz, normal posterior activity in relaxed, awake individuals with eye closed, goes away with attention or stress, etc. Theta 4 to 7 hertz and delta is less than 4 hertz. Slow waves seen in sleep and in certain pathologic conditions. Benzodiazepines and barbiturates induce slowing, abnormal in the adult awake. If this occurs, then it is abnormal. He is having seizure. Electrical activity of the brain on EEG during a seizure, that is on the left below side, that is seizure is having, that is pause also and immediate is there. Delta waves slow, you can count those waves in EEG. Other testing CSF examination by lumbar puncture obtunded individuals when meningitis or encephalitis is suspected. Your meningitis and encephalitis can also cause seizure activity. If concern exists for subarachnoid hemorrhage, ECG is indicated for individuals with hypoxic seizure presenting as cardiogenic syndrome. Then metabolic, cardiogenic, and psychiatric causes of seizure-like episodes. Management. How to management? Isolated or first time seizures. Stabilize individual and then initiate evaluation in the emergency room and monitor for life-threatening cause of seizure. Many seizures resolve on their own without intervention. Abortive therapy with benzodiazepines or anticonvulsant medications are not indicated in the initial stabilization of individuals with isolated seizures. Admission is not needed and close outpatient follow-up can be arranged. Antiepileptic medication starting treatment after a single unprovoked seizure remains controversial. Goal of treatment is a seizure-free status, no adverse effects. Causes of unprovoked seizures with higher chance of recurrences include pre-existing brain lesion, presentation with status epilepticus, presence of epileptic discharges on EEG, family history of epilepsy. Anti-epileptic drugs are sorted by mechanism of action. This is mechanism of action of anticonvulsants. That is GABA, that is inhibitory pathway. GABA man, that is GABA receptors. Phenobarbital, these all act on GABA receptors. Phenobarbital, pyrimidine, benzodiazepines, triazepam, vigabatrin. Carbonic anhydrase, topiramate, zonisamide, many means it acts on many receptors, valproic acid. Then sodium channel phenytoin, that is we give Epsolin, that is phenytoin, then carbamazepine, osamazepine, lamotrigine, lacosamide, topiramate, zonisamide. Then potassium channel operant, it is that glutamate pathway is potassium channel operant due to which positive dose and more that is depolarization occurs and then activation of the membrane potential. Okay, exoderm, that is these two drugs. Then calcium channel blockers. The first one is very important. Ethosuximide type C calcium channel blockers. It is used in absence seizures. Absence seizures, the drug of choice is ethosuximide. Then gabapentin and pregabalin, which we give. Then SB2A is a levetiracetam. SBTA is also, it is a GABA pathway, so it is a receptor, which is blocked, levetiracetam. Then other are the rufinamide and felbamate. Status epilepticus, rapid stabilization and history and physical screening. Abortive therapy hallmark is IV, benzodiazepines, agents are lorazepam, diazepam, midazolam. Midazolam, the dose is 10 mg IM and lorazepam is 2 or 4 mg IV. Definitive treatments indicated to prevent recurrences of seizures, equal efficacy among levetiracetam, fospheniton, valproate. Refractory cases, greater than 60 minutes of seizure activity, airway protection by intubation and sedation, continuous EEG monitoring should be done, supplement with phenobarbital and sesquoniton. In these cases, loading dose is given to the patient for the stabilization of the patient, of which either the loading drug of choice is levetiracetam. Surgical treatments indicated in refractory status epilepticus or refractory epilepsy. Examples of procedures include resection of specific seizure nidus, that is surgical procedures, vagus nerve stimulation, brain stimulation, and deep brain stimulation. Management, that is seizure preventive measures, psychoeducation of individuals to avoid common triggers, sleep deprivation, alcohol, certain drug types, opioid stimulants, some anti-cancer drugs, some antibiotics, some immunosuppression. Abstinence from operating motor vehicles may be required because anytime seizure which can cause trigger doesn't know. Differential diagnosis, how to differential diagnosis from seizure. Syncope, brief loss of consciousness and muscle tone with spontaneous recovery. Syncope has numerous causes, but it is usually a result of decreased blood flow to the brain. Those with syncopal events do not have the post-ictal confusion or prolonged duration of unconsciousness that are prevalent in those with seizure events. Management of syncope includes identifying and treating the secondary cause. Migraine, headache disorder characterized by headaches that may be associated with increased sensitivity to light and sound as well as nausea. The clinical features of seizures depend on the location of the seizure focus and may not necessarily present with a severe headache that are the hallmark of migraines. Management strategies of migraines include controlling acute episodes as well as prophylactic treatments. Psychogenic non-epileptic seizure resembles epileptic seizures, but there is no defined cortical EEG activity would be diagnosed in epileptic seizures. Subtle physical exam findings differentiate PNES from the true seizures, including closed eyes in convulsing individuals with PNES. Management includes potential admission to the epilepsy observation unit with video EEG monitoring. Hypoglycemia, emergency condition defined as serum glucose less than 70 mg per dl. Hypoglycemia may present with a variety of non-specific symptoms, including adrenergic symptoms and neuroglycopenic symptoms such as seizures. Diagnosis is based on serum glucose measurement and clinical presentation. Management is with oral glucose, that is drug of choice D50, IV dextrose or IM glucagon, and frequent serum glucose checks. Narcolepsy, neurologic sleep disorder marked by the daytime sleepiness and associated with cataplexy, hypercapnia, hallucinations, and sleep paralysis. Diagnostic criteria are identified using sleep studies that show a decrease in REM latency. Management includes good sleep hygiene. Medications that as a CNS stimulants and antidepressants are used to target the cataplexy. Summary: a seizure is an abnormal electrical activity of the neurons in the cerebral cortex that can manifest in numerous ways depending on the region of the brain affected. Seizure consists of a sudden imbalance that occurs between the excitatory and inhibitory signals in cortical neurons, creating a net excitation. The two major classes of seizures are focal and generalized. Diagnosis is clinical, relying on history and physical examination, but also may use EEG and other tools. Management includes both abortive and preventive medication, but may not be required in self-limited cases with no etiology found during workup. Epilepsy is a chronic brain disorder marked by recurrent and unprovoked seizures. These seizures can be classified as focal or generalized and idiopathic or secondary to another condition. Clinical presentation correlates to the classification of the epileptic disorder. Diagnosis is confirmed with EEG, while some epileptic disorders resolve over time may require lifelong anti-epileptic medication for management or in some refractory cases surgical procedures. Thank you.